Hello there. I am Will Reiter, Education Program Manager at the Association for Frontotemporal Degeneration. I'd like to welcome you to our virtual session, FTD Diagnosis and the Hispanic Latino Community. I'm sure many of you know that the experience of getting an FTD diagnosis can be long and frustrating. The average time to diagnosis takes 3.6 years. Anecdotal data, along with general information on health outcomes by race, suggest that Hispanic Latino families face an even more difficult diagnostic journey. In this breakout session, neurospecialists in dementia from Indiana University and the University of Texas, Health San Antonio will discuss their work with Hispanic families. They'll highlight research they are involved in, as well as how they work to increase awareness and earlier FTD diagnosis. But before I introduce our first speaker, I have a few slides of information about resources that AFTD provides. So upcoming in just a couple weeks, on the 15th of May, we have a meet and greet session in Spanish that will be offered 8 to 9:15 p.m. Eastern Daylight Time. The session is noted within your conference booklet on page 37. There are 3 AFTD volunteers that will be hosting that session in Spanish, and it's an opportunity for families living with FTD to meet virtually and to hear about resources and supports. In order to get more information about that session, people should be contacting by email Sandra Gonzalez Barrett, whose email is noted at the bottom of this page and is also within our booklet. And we're looking forward to having a really engaging discussion and helping families to connect. This slide gives you an overview of the various resources that AFTD can provide in Spanish. And it's a broad collection of information of an overview of the FTD disorders, specific information about BVFTD and PPA as far as diagnostic checklists. There are some awareness cards that persons with FTD and their family members can share with others to help communicate about some of the challenges and the symptoms. Again, these are all in Spanish. And then we have a number of other resources. For more information on those resources, you can contact our helpline either by email or by our helpline number listed at the bottom of this page, and we are able to respond to helpline contacts in Spanish. And then finally, I just wanted to highlight a recent study called the Beyond Study, specifically looking to connect with and learn from people with younger onset dementias from diverse communities. There's information on this slide, www.beyondproject.org, or a phone number to call for more information. I now will be introducing our first speaker and will proceed on with the program. Our first speaker, Dr. Patricia Garcia, is a clinical neuropsychologist and assistant professor of clinical neurology and physical medicine and rehabilitation at Indiana University School of Medicine. Clinically, Dr. Garcia evaluates a variety of adults who present with acquired and neurodegenerative diseases. She conducts neuropsychological evaluations in English and Spanish, working directly with Hispanic older adults and their loved ones. I'm pleased to welcome Dr. Garcia to the screen to join us, and she will be sharing her slides momentarily, and she will then highlight for us some of the work that she and her colleagues at the University of okay, our speaker is having some difficulty opening up their video. Millie, I don't know whether you want to communicate with Dr. Garcia directly. I think what we might do is pivot to up. Millie, Patricia, Dr. Garcia is saying that she no longer has access. It may have been when you stopped the viewing and the audibility of our audience. So I'm not sure if you have a way to open that back up again for Dr. Garcia.
She should have access to it.
I still don't have access to my video, my camera.
Oh, to the video.
Yes, it says you cannot start your video because the host has stopped it.
Can you still share your slides?
Let me see. I can try that.
Yes, because we can hear you.
Okay, all right.
We can certainly work on, it'd be great if the audience could see you. And maybe we can resolve that
Sure.
as we go along.
Sure,
But
sure.
if you're able to share your PowerPoint slides, we could continue on with the program that way.
Of course, let me try that.
We can definitely see your slides.
Yes.
Yes. So yes, Dr. Garcia, we now can see your slides from the beginning.
Okay.
So I'm gonna go, I'm gonna mute and go off video. And why don't you go ahead and proceed with your presentation? And while you're doing that, Millie, you'll see what you can figure out potentially seeing Dr. Garcia, if not during her presentation, then at the end, and also verifying that we'll be able to see our next presenters. So sorry about that, Dr. Garcia, but we can hear you and we can see important information. So let's forge ahead.
All righty. Thanks, Will. I appreciate it. And thank you, Melanie. All righty. So thank you, everyone, for joining us in this breakout session. The emphasis of our talk is going to be the challenges associated with diagnosing someone who identifies himself as Hispanic, Latino, and the many challenges associated with diagnosing them with a frontotemporal dementia syndrome. So for the next few minutes, I would like to share with you some of the disparities that now we've come to know and appreciate that contribute to this delay in this frontotemporal diagnosis. And I will be ending my talk by sharing with you about some exciting projects that are ongoing at the School of Medicine that hope to serve the ADRD and more specifically the Hispanic community in Indiana. And so this is just a visual reminder why it's important and why I'm so appreciative of conferences like this one that provide such a national platform for really underscoring the importance of continuing to work with Hispanics and Latinos in the US. We know that this is a fast-growing group. Now we are seeing even multi-generation of Hispanics within the US in some specific states in the country. And if you happen to be a provider here in the audience and you think of yourself or you are bicultural, bilingual, or even if you're not, and just have an interest in cross-cultural neuropsychology or cross-cultural medicine in practice, this is your encouragement for why working with this group.
And Dr. Garcia, I wanted to let you know we can see you as well now.
Wonderful.
So you have joined us. Thank you.
Okay, fantastic. Okay, so let me there, okay. So in terms of barriers and contributing factors for a delay of diagnosis, we have barriers from multiple angles, but before we get into the specifics, I do want to provide you with some context. And that is that when we compare underrepresented groups, Hispanic and Latinos do have or do receive a later onset of FTD diagnosis, which of course, when they do eventually make it to your office, the syndrome is a lot more advanced, both in terms of atrophy that shows in the brain, as well as quite a diffuse cognitive profile and pretty low cognitive scores in the neuropsychological assessment. And so at a clinician level, when we look at those barriers, overall, we seem to have a wider familiarity with Alzheimer's disease as a syndrome. And this is the case for clinicians. It is the case for patients and families. And so implicitly, there seems to be an association between dementia with memory deficits, which of course we know that with frontotemporal dementia, memory deficits are just not a core feature of this syndrome. We also see a small number of medical specialists, particularly neurologists and psychiatrists, who receive limited training pertaining to better identification of behavioral variant of the frontotemporal dementia syndrome. And so with limited training, sometimes comes limited exposure to that patient population. And sometimes with limited exposure and limited training, we also see misinterpretation or misattribution of symptoms. And so, for example, we have about 50% of patients that eventually get diagnosed with behavioral variant FTD diagnosis. They first receive care for psychiatric management. And so there's a misattribution of symptoms. They assume that this is primarily psychiatric. They receive psychotropic treatment for the management of those symptoms. And then later is when it's a lot more clear to the treating provider that this was frontotemporal dementia. We also, in terms of the profession, and this is a little more specific now to neuropsychology, and again, this is a topic that we could spend multiple discussions on, but I will just keep it short by way of reminding us that when we think about the cognitive assessment, a lot of our tests, a lot of our tools that we use in practice have been validated, have been created, have been normed on very specific groups with very little representation of Hispanic groups in that normative sample. And so when we think about now applying these tools in individuals that are Hispanic, that were either born and raised in Latin America and came to the US, or have Hispanic ancestry, right? So their families are from Latin America. The issue of cultural relevance or cultural appropriateness or cultural validity gets raised, rightfully so. Okay, so I'll stay with that slide. And so with that, I do want to underscore that the neuropsychologist is still the quite a provider that is able to appreciate the nuances, appreciate the subtleties, especially when we consider that the cognitive profile of FTD encompasses language impairment, encompasses executive dysfunction, and even social cognition deficits. The neuropsychologist is very well trained and quite equipped at appreciating those subtleties and helping guide the diagnostic process. And while I think that the clinical knowledge will always be your foundation, I don't think necessarily that is sufficient for when trying to work and provide a service with Hispanics. And so if you are a cross-cultural neuropsychologist, you have both the clinical training, but you also have the cultural expertise. You understand a thing or two about the culture of the patient sitting in front of you, and you have even a pretty well-rounded understanding of just even the language profiles that you're likely to encounter if you're working with someone that is a monolingual English speaker, and the subtleties and the deficits that may show up with that patient versus the monolingual Spanish speaker and the deficits that you're likely to see instead. And so at a patient or family level, we still see dementia overall, and again, FTD and or just more broadly speaking, dementia, it's still pretty under-recognized and under-treated in our Latino community. There is a minimization of symptoms and implications of these symptoms. And it's not uncommon for the Hispanic patient sitting in front of you to tell you how their symptoms are just normal. They're expected because they're only getting old. And so there's a clear misinterpretation and, again, sort of minimization of what could potentially may be going on and when it stops being normal aging and now it has crossed that threshold of more abnormal aging. There's also quite commonly, we talk about how the comfort level that Hispanic patients have in terms of just feeling more comfortable in speaking with their religious leaders and other members out in the community, more so than speaking with doctors. And this is not a barrier per se. I think this is just a reminder that if you are a provider wanting to work with this community, you have to get good fast at identifying who are my allies in this Hispanic community so that I can better reach this population that I'm trying to treat. There is also the not really being sure what symptom I talk about in the medical appointment. And so when I work with residents, I remind them that you have the symptoms that helped the patient make it to you. And then you have the symptoms that are symptoms that are happening for this patient. And they're not gonna bring it up because they're not even sure that clinically it makes sense to talk about that symptom unless you ask in the course of your encounter with them. And of course, when we think about migrant communities, the lack of medical insurance is a big barrier for accessing care. And even low levels of health literacy. This is a concept that's coming up more and more. Even when you do cross-cultural comparisons, Hispanics actually score much lower than other underrepresented groups, specifically looking at health literacy aspects of care. And finally, more systemic, this is again outside of the patient, outside or beyond the profession of neuropsychology or medical doctors. There's obviously, when we think of systemic barriers, we think of low-income neighborhoods. We think of issues of, again, if this is a low SES area, they're likely to not encounter or have access, readily access to diagnostic tools such as a PET or an MRI even for diagnostic purposes. We have the issue, of course, of culturally, as a culture, Hispanics are less proactive when it comes to preventive medicine. They only treat symptoms when they are happening. And so it's more of reactive medicine. And again, this is a cultural foster mentality that when they do come from Latin America to the US, that continues being the case. And so this actually contributes to why an elder Hispanic may not think that if I'm only in my 60s, I should be able, or I should be thinking about caring for my vascular health because nothing is really going on as of yet. And then, of course, we have issues that pertain more specifically to the underrepresentation, the marginal representation of Hispanics in research, which I cannot underscore enough. And finally, I just wanted to end on a positive note. This is just to share some of the exciting things that we have going on. We now have at the IADRC, the Hispanic Community Advisory Board. This is a group that allows us to engage in monthly and quarterly educational sessions. We are providing now webinars and community engagement with folks. We now have a funded pilot project titled Advancing Hispanic Outreach and Retention in ADRD, Ahora Research Initiative, which looks to better understand the barriers and engagement factors for why to apply and engage with research. Of course, this is a little, it's actually more specific to Hispanics. And we have other research collaborations in the works, more specifically looking to reduce stigma associated with ADRD in Latino groups. Thank you.
Thank you very much, Dr. Garcia. We're glad that you could join us and that we were able to see you, and we'll invite you back at the conclusion when we have time for questions. So I am now going to move on to our next speakers who I will introduce together. Dr. Alicia Parker completed medical school at UT Health San Antonio, a neurology residency at Baylor College of Medicine, as well as a cognitive and behavioral neurology fellowship at the University of Florida. Dr. Parker established the Memory Disorders Clinic and the Multidisciplinary Mind Clinic. And she also, working along with Dr. A. Campbell Sullivan, co-established the FTD Clinic, which specializes in treating patients with behavioral and language disorders. She is a primary investigator for multiple clinical trials. At the conclusion of her presentation, she'll be inviting her colleague, Dr. A. Campbell Sullivan, who is an associate professor of neurology and a board-certified clinical neuropsychologist at the Biggs Institute for Alzheimer's and Neurodegenerative Diseases at UTHSA. She serves as a clinical co-lead for the South Texas Alzheimer's Disease Research Center and co-director of the Biggs FTD program. Dr. Sullivan is the site primary investigator for all FTD, a comprehensive longitudinal multi-site study targeting all variants of FTD. Dr. Parker, I'm glad that we can see you and we can see your slides, and welcome.
Thank you so much for that wonderful introduction. Can y'all hear me okay? Great. So I'm Alicia Parker. I'm a cognitive and behavioral neurologist, meaning I'm a neurologist who studies a person's ability to think and the medical problems that can happen when there is some trouble with thinking or how your brain's functioning. I'd like to say that Dr. Campbell Sullivan and myself essentially started a lot of our clinics and our multidisciplinary clinics with a focus on helping underserved populations and our very large Hispanic population that we have in South and Central Texas. And it's been really a pleasure to help build up some of these programs. So let me just jump in here. So I'm going to be focused on talking about some of our clinical programs and our clinical overview at the Glenn Biggs Institute, which is at UT Health San Antonio. Here we go. So just very briefly, with the diagnosis of frontotemporal dementia, I'm sure y'all are quite aware about the typical long delay for diagnosis, sometimes which can take quite a few years with a lot of misdiagnoses initially. So when there's some worry about symptoms of FTD or frontotemporal dementia, initially a person would go see their primary care or their general physician, and then that would result in a referral to neurology, or if you have the ability to go to the cognitive and behavioral neurology subspecialty, then that's really wonderful as well. Then there's typically some cognitive or thinking testing with the neuropsychological evaluation. And then often we do different labs to look for things which can affect the brain. And then a lot of time there's brain imaging, either structural imaging like MRIs or CT scans or different kinds of PET or other functional imaging. And the image that you see over here on the right is a FTG PET scan, which is looking at glucose metabolism in a patient with behavioral variant FTD. you can see that there is less metabolism up in the frontal lobes. You can tell this is the frontal lobes because this is the nose over there. Okay, anywho, so at the Biggs Institute, we've always wanted to take a comprehensive approach. So a lot of our clinics are set up to be multidisciplinary. So Dr. Sullivan and I started the MIND clinics, which is management and intervention in neurodegenerative diseases, which is joint, where a person would first get their cognitive evaluation with neuropsychology, and then they would wrap up with me in behavioral neurology. And then over time, we've added psychiatry, geriatric medicine. We have a really lovely social worker, genetics counselor. Our genetics counselor is also giving a talk later. That's Julie Castro. And then we also like to have a caregiver counselor. There are a multitude of clinical research programs, and we've been very fortunate to have some great caregiver support programs as well. With regards to overall patient visits, in the last year, so in 2023, we saw about 95 patients who had one of the variants of FTD or a primary progressive aphasia diagnosis, and about a third of them self-identified as Hispanic. And then with some of the FTD spectrum disorders with associated Parkinsonism, we also had a pretty good Hispanic representation as well. So 1 out of the 7 patients were diagnosed with cortical basal degeneration, identified as Hispanic, and about a third of the patients with progressive supranuclear palsy. It's really important to share and track that because in general, these FTD spectrum disorders are not well recognized in Hispanic populations, which can make it harder to miss that diagnosis, make the correct diagnosis, come up with an appropriate treatment plan and support. So we do a few things to try and reach out to the community to let them know we're here to help. We have some outreach clinics. There's one in Laredo, which is an area that doesn't have very good access to neurology in general. And so that's been really helpful for us to add a Spanish-speaking neurologist and a Spanish-speaking geriatric medicine doctor there. And then we're opening a clinic in the Robert Brady Green Clinic in San Antonio, which is in an underserved, predominantly Hispanic part of the city, which should be opening in a couple of months. We have some support groups as part of our clinical program that are run by our social worker and our caregiver counselor. So 2 of them are focused on, well, one of them is for caring for a patient with dementia. So for adult children who are now the caretakers of their parents, which can really be a difficult transition. And then we also have a grief and loss support group. So for people who are experiencing the grief of kind of losing the person that they knew and loved and having to step into a caregiver role, and that can be very difficult as well. We do a number of community engagements. Some of the ones that we just wanted to talk about is that we have quarterly art museum visits, which are free for people with dementia and their caregivers, and then Meals on Wheels and Grace Place help sponsor the meals associated with that, which is really nice. Went forward too much there. There's virtual yoga as well, which is currently on pause for another month or so, whilst the person who is leading it is on leave, but she's doing fine. And then there also, for the most part, is an annual symphony visit with the San Antonio Symphony during one of their later dress rehearsals. So it's kind of a quieter, easier event for people with FTD to enjoy because the whole auditorium is not filled. It's just the small group. Okay, and as I mentioned, we have a really great caregiver counselor, Melissa Flores. She generally works with family members and caregivers to provide support and help. And then we have Angela Torres, who is our social worker, who helps with also all kinds of resources and support. And the 2 of them basically run a lot of our support programs. And then Natalia Monroy also joined recently as our care ecosystem navigator that I'm fairly positive Dr. Sullivan will talk about as well, which is specifically for people with behavioral issues such as frontal temporal dementia and making sure that there's a lot of extra support and care just to help families navigate through all these challenges. And that was all I was going to talk about today. Thank you. Or maybe I should just introduce Dr. Sullivan.
Okay. You need to stop sharing your screen though.
Great idea. All right, so next up, it's my absolute pleasure to introduce Dr. Sullivan, who's a world-class neuropsychologist with a focus on young onset dementia and providing all kinds of different help for them. All right, I'll let her take it away.
Wonderful. Thank you, Dr. Parker. And thank you guys so much for having us here. So as Dr. Parker alluded to, we've been working together for quite a while. And we work in San Antonio, and we partner with our colleagues all across South Texas. And we have a really lovely, wonderful cohort of Hispanic and Latino patients and participants. And it wasn't that long ago that I was at a national conference and I was told, well, FTD doesn't occur in the Hispanic population. And I remember just being sort of appalled and shocked because it certainly wasn't the case in our practice. And so that just let us know that we needed to be a louder voice and be a stronger advocate. And so I'm going to talk to you about some of the things that we have done over the past several years with clinical research going on at UT Health San Antonio and with our partners down in the Valley. And so recently, I shouldn't say recently, but I guess in the past 3 years or so, we were awarded an NIA-funded Alzheimer's Disease Research Center. It's not letting me progress. Oh, there it is. And so we have a huge catchment area. I mean, Texas is a big state, and we have a lot of people, but we're also the friendly state. So we make a lot of friends and we collaborate quite effectively. So we partner with our colleagues down at UTRGV, so down in Brownsville and Harlingen and McAllen, but also our partners over in Laredo. And so with these 3 sites combined, we're covering over 12,000 square miles. But our goal is really to sort of raise awareness of Hispanic and Latino participants in clinical research. And so a lot of times what we do is we'll recruit straight from clinic. And have, them go through and participate in our ADRC, and we do evaluations, and we might take pictures of their brain, and then we take their name off everything and send it to a national sort of database, a national repository, so that scientists from all over the world can request to analyze these data and hopefully come up with, treatments or causes or, just do more research. And so we do this, we really want to emphasize the disease across the disease spectrum. And so we are looking at community-based enrollment and engagement. So we have participants who don't necessarily have a cognitive diagnosis yet, but they're noticing cognitive changes. We also have like healthy controls, and that is managed primarily by our population neuroscience core from the ADRC. And so through this core, we have promotoras who are going out into the community. They're doing different research and educational events, and they're enrolling participants. And then we're collecting data from these participants every single year, as long as they want to, of course. And then we have that sort of bleed over into our clinical course. So we're taking people straight from clinic. So a participant who's seen Dr. Parker, who is interested in participating in clinical research, she can enroll them right from clinic. And might look at some biomarkers. So looking at some blood, we might do some genetic testing. We might take pictures of their brain. And we take all this data, take names off of everything, and then start to analyze it. And our goal really was to create this really deeply phenotyped, rich data set of Hispanic and Latino participants all across South Texas. And I will say, if we look compared to all of the other ADRCs in the country, we are very successful. So over 50% of our cohort identifies as Latino or Hispanic. And so we are very much sort of outpacing everyone when it comes to engaging Hispanic participants into clinical research. And so here's just a breakdown of our current cohort. So the last time I did this slide, which was a month or two ago, so those numbers are probably off by about anywhere from 20 to 40 participants, we had about 453 individuals that we have been studying over the past 2 to 3 years, and we're always recruiting more. And more than half of those individuals are identifying as Hispanic. And we have the breakdown of clinical diagnosis. And as you can see, over half, nearly half are normal. And so that means we're going to follow them over time to see sort of how symptoms evolve and develop and occur. And a large portion of them are in the mild cognitive impairment state or have sort of an amnestic dementia, which is like your typical Alzheimer's dementia. Much fewer participants have a frontotemporal dementia. And so that's where I come in, because FTD has always been my passion, and it's always how I've really organized my training, my education, and my clinical practice. And so for the next foreseeable future, we're really focusing on trying to increase recruitment of underserved individuals, primarily Hispanic Latino populations with FTD diagnosis. And so that's where we were invited to participate with the All FTD study. This is another longitudinal observational study. There are several sites all across the country, and we were added on last year. And so over the past year, we have recruited about 27 individuals with suspected FTD syndromes. We also have individuals who are from a family, sort of a familial form of FTD, but they're asymptomatic. And this is a busy slide, but I just want you to look here at this middle line, and this is San Antonio, and this red portion you see, this is our proportion of Hispanic individuals. And so we again are leading the country in recruitment of Hispanic individuals with FTD diagnoses. Now, if you look over here, it's a little less exciting because we only have 9, but we're growing steadily each month. And that's why we're doing talks like these, to sort of let people know that we are here, we are interested. If you want to participate in clinical research, we would love to have you and just bring you into the family and see you every single year. But it's a little bit challenging to do, because contrary to sort of some of these other sites across the country, our cohort is truly bilingual. So a lot of ADRCs or studies in Florida or in San Diego, their patient population is predominantly monolingual. And so we have this sort of very complicated rubric of how do we even evaluate and begin to diagnose bilingual individuals with language disorders like FTD or behavioral variant FTD. So what are we looking at? And so we're sort of leading the charge here, deciding, if someone is Hispanic, if they are bilingual, how can we evaluate, or how do we determine if we're going to evaluate them in English or Spanish? Historically, we did it on patient preference, but there's a lot of stigma associated with that. So now we're looking at, we're just assessing language dominance. And if we look at our South Texas cohort, we're highly unique in that, we give them a test. We do the test in English, we do the test in Spanish, and then we try and see, are you stronger in English or Spanish? And majority of our patients, so if we just ran this in 33 participants, random sample, so 0.50 is truly bilingual in English or Spanish, and we're at 0.497. So we really want to take that into account, and we want to evaluate people in language with their strongest in. But also lets us know that we need to get to a point eventually where we can do sort of a bilingual assessment of bilingual individuals, where we can they can respond in English or Spanish. The goal is to get the best performance from them possible. But we also want to sort of look at linguistic history surveys. We want to look at acculturation. So there's a lot of areas where we're starting to look at and determine and sort of help others and other centers capture the most precise and valid and culturally appropriate data possible. And then not only do we want to, help families come up with diagnoses and help study these families over time and help come up with treatments, but really our goals are to help families manage the disease process and do so through our caregiver support, because as I think probably many people on this call can appreciate, it's really hard on families. So we partner with UCSF, we partner with Oregon Health to really provide sort of targeted interventions for families who are dealing with behavioral dementias. As Dr. Parker mentioned, we have bilingual counselors, we have our promotoras, and we have all of our community and educational events, not only for the communication, the communities, but also for other providers and community providers to really sort of raise awareness of FTD in general, but also within our Hispanic Latino communities, because our goal is to sort of cut down on that lag, that diagnostic delay between onset of symptoms and getting an accurate and true diagnosis. So that's where some of the strides that we are making, and it wouldn't be possible without this amazing team of researchers, and this isn't even everyone. So thank you very much. I probably spoke too much, but I appreciate the opportunity to be here. So thank you.
So thank you, Dr. Sullivan and Dr. Parker. I'll invite Dr. Parker and Dr. Garcia to join us again. You all really gave us a much more comprehensive and richer perspective on the successful work that you're doing with this complicated challenge of outreach and awareness and detection and better diagnosis. And I think there was some questions around engagement activities, and I think Dr. Garcia, you responded to that. Would you all agree that a program that has both a very extensive and multi-pronged outreach, detection and diagnosis approach, but also a rich engagement experience for Latino Hispanic families really is one of the best ways to engage people and keep them involved and invested, and also by word of mouth to expand the success. I see your heads nodding. If anyone wants to say a few words, we have just a couple minutes left.
Yeah, I think sort of, just engaging with the community. And, the concern always with any sort of like clinical research is that we're just taking, and we're not building this relationship and we're not building this rapport. And really, I think our goal is always to sort of like let all of our participants know that, we're in this together. And so we might be collecting some data, but we're going to try and give you results back, and we're going to try and educate you and make you sort of a part of the team. And so, we need your help sort of directing us and directing our research and making sure that we're answering questions that not only scientifically we're interested in, but as a community and as a cohort, you guys are interested in. And so it's definitely a partnership. And so I think that that's something we try to emphasize a lot. And also, like, we're not going anywhere, like we're here, we're in this, we're gonna, hold your hand all the way through as long as you want to be a part of it. So I think that those are important factors.
Thank you.
Yeah, I would second what Dr. Sullivan said. Relationship comes to mind. And so we talk about partnerships, and with this ethnic community, relationships are the foundation for any conversation, for any sort of engagement, any metric that we come up with. The foundation has to be really taking care of those relationships and demystifying, I think, some of the research as it's presented to the community, and letting them know that this is mutually beneficial. You are helping researchers while the research studies are helping you, your family, and your loved one.
So I will share with all three of you that one of the final comments was someone who works on health equity in New York State, and they said this was a fantastic presentation, exclamation point. So again, thank you so much for joining us. We're going to bring it to a close and go for a 15-minute break. And those of you that are joining us virtually. The next session will start on the hour. Again, thank you so much. Really appreciated your time and the great information. Take care. Bye-bye.
Thank you, everyone.
Bye-bye.
Thank you.